Hey everyone, Dr. Mike here. Today we're going to talk about a condition that might sound complicated, but we're going to break it down so it's easy to understand. We're discussing congenital hepatic fibrosis, or CHF. The word congenital simply means it's something you're born with. Hepatic is the medical term for anything related to the liver, and fibrosis means the scarring of tissue. So putting it all together, CHF is a condition where a person is born with scar tissue in their liver. This isn't scarring from damage or lifestyle choices. It's caused by a problem with how the liver developed before birth. It's a rare genetic disorder, meaning it's passed down through families. Now you might be wondering what this scarring actually does. Think of your liver as a super efficient filter and factory for your body. It cleans your blood, helps digest food, produces important proteins. In CHF, the development of these structures, specifically an area called the ductal plate, goes wrong. So how do you know if someone has CHF? Symptoms can be tricky. They vary a lot between people. They can show up at different ages. Some people have no noticeable issues until they are teenagers, or even young adults. Others show signs in early childhood. The most common serious symptoms relate to portal hypertension. Blood can't flow easily through the scarred liver. It backs up, like a traffic jam on a highway. That pressure causes problems that become first clues. One dramatic sign is bleeding from varices. Varices are enlarged, fragile veins in the esophagus, varices in the stomach. Those veins can rupture and bleed, a medical emergency. It can appear as vomiting blood, or black, tarry stools. Another major sign is an enlarged spleen, splenomegaly. An enlarged spleen can trap blood cells, causing low platelets. Cholangitis can cause fever, abdominal pain, and jaundice. Alright, let's play detective. When a patient comes in with symptoms like an enlarged spleen or bleeding, how do we connect the dots to diagnose CHF? The process is a step-by-step investigation, starting with the basics and moving to more specialized tests. It all begins with a thorough physical exam and a detailed medical history. A doctor will feel the abdomen to check for an enlarged liver or spleen. They'll ask about any history of bleeding, abdominal pain, fever. They will also ask about family history, since CHF is a genetic condition. The next step is heading to the lab for blood tests. These tests give us a snapshot of what's happening inside the body. We'll run a complete blood count, or CBC, to look for signs of an enlarged spleen trapping blood cells, like low platelet counts. We'll also order liver function tests, or LFTs. Here's the interesting part about CHF. The results of these tests can often be normal or only slightly abnormal. This is because, as we discussed, the liver cells themselves are often still doing their job. This finding of normal liver function in the face of other symptoms is actually a big clue pointing toward CHF. If the physical exam and blood tests raise suspicion, the journey continues. The doctor will want to rule out other, more common causes of liver problems, like viral hepatitis. It's a process of elimination. Once other conditions are ruled out and the evidence for CHF is mounting, we move on to the next phase of the investigation: imaging. Now we get to the cool part, the technology that lets us see inside the body. To diagnose CHF, imaging is king. The first and most common imaging test is an abdominal ultrasound. It's non-invasive, uses sound waves, and gives us a great initial look at the liver, spleen, and kidneys. On an ultrasound, a doctor can see if the liver and spleen are enlarged. Importantly, an ultrasound with Doppler, which shows blood flow, can help identify signs of portal hypertension, like changes in blood flow direction in the portal vein. If we need a more detailed picture, we might order a CT scan or an MRI. An MRI, especially a type called an MRCP that visualizes the bile ducts, can be extremely helpful. It can show the abnormal, dilated bile ducts that are a hallmark of CHF and its related conditions. These advanced scans provide a high-resolution view of the abdominal organs, allowing doctors to assess the liver's structure, the size of the spleen, and the presence of varices with much greater detail. They are also excellent for examining the kidneys to check for the cysts associated with ARPKD. To directly look for those dangerous varices in the esophagus and stomach, we use a procedure called an upper endoscopy, or EGD. This allows the gastroenterologist to see the varices firsthand, assess their size, and determine the risk of bleeding. If needed, the doctor can even perform treatment during the endoscopy, like placing tiny rubber bands around the varices. Finally, the gold standard for confirming CHF is a liver biopsy, though genetic testing can sometimes confirm the diagnosis without one. Once CHF is diagnosed, The focus shifts to managing the symptoms and preventing complications. There is, unfortunately, no cure for the underlying fibrosis, so treatment is all about tackling the problems it causes. The most urgent issue is often portal hypertension and, the risk of bleeding from varices. The main goal here is prevention. Doctors may prescribe medications called beta blockers. These drugs work by lowering the pressure in the portal vein system, which reduces the strain on the varices and makes them less likely to bleed. If varices are large or have bled before, we use endoscopy to treat them directly. The most common method is variceal band ligation. During an endoscopy, a doctor places small, tight bands around the base of the varices. This cuts off their blood flow, causing them to shrink and disappear over time. This procedure might need to be repeated every few weeks or months, until all the large varices are gone. It's a highly effective way to control bleeding risk. In emergency situations where there is active bleeding, this procedure can be life-saving. Another major concern is the risk of bacterial cholangitis, the infection of the bile ducts. Because the bile ducts are malformed, bile can stagnate, making it easy for bacteria to grow. The main treatment for an active infection is antibiotics, usually given intravenously in a hospital at first. For people who get these infections frequently, a doctor might prescribe a low-dose antibiotic to be taken daily as a preventive measure. It's also important to manage any symptoms of cholangitis, like fever, chills, or abdominal pain, very seriously and seek medical care right away. In some cases, especially with recurrent cholangitis, an ERCP may be needed to open blockages, remove stones, or place stents to help the bile drain properly. Managing these two major risks, bleeding and infection, is really the cornerstone of CHF care. By staying on top of screenings and treatments, patients can significantly reduce their risk of life-threatening complications and maintain a good quality of life. While we focus a lot on bleeding and infections, managing CHF is about more than just that. Comprehensive care also means paying close attention to nutrition and overall growth, especially in children and adolescents. Regular monitoring of growth charts in children and weight in adults is a simple but effective way to ensure their nutritional needs are being met. Working with a registered dietitian is a fantastic idea. They can help create a balanced eating plan, calories, protein, vitamins, and minerals. Doctors will often recommend supplements, particularly for fat-soluble vitamins, A, D, E, K, as bile flow issues can sometimes interfere with their absorption. In a small number of cases, when portal hypertension or recurrent life-threatening infections become overwhelming, a liver transplant may be considered. A transplant replaces the fibrotic liver with a healthy one, effectively curing the liver-related aspects. But it requires lifelong care. For patients who also have significant kidney disease from ARPKD, a combined liver and kidney transplant might be the best option. The decision involves doctors, surgeons, social workers, and psychologists to ensure the patient is ready, and it can offer a chance at a new beginning. Living with a chronic condition like CHF means being an active partner in your own healthcare. Your daily choices can make a huge difference in managing symptoms and reducing risks. One of the most important lifestyle rules for anyone with a liver condition is to completely avoid alcohol. The liver is responsible for metabolizing alcohol, and this process is stressful even for a healthy liver. Regular medical checkups are your best friend. Don't skip them. Your doctor will order routine blood tests and schedule periodic endoscopies to check on varices. Staying on schedule with medications, beta blockers, preventive antibiotics when prescribed, is critically important. Be careful with over-the-counter medications. Some drugs, particularly NSAIDs like ibuprofen and naproxen, can increase bleeding risk and should be avoided. Keep a personal health record, medical history, medications, and test results. Being your own advocate is one of the most effective tools in managing a long-term condition. Because CHF is a genetic condition, it naturally brings up questions and concerns for the whole family. It's usually inherited in a pattern called autosomal recessive. Autosomal means the gene involved is not on the X or Y chromosomes that determine sex, so it can affect males and females equally. Recessive means that to have the condition, a person must inherit 2 copies of the mutated gene, one from each parent. There is a 1 in 4 chance that the child will inherit 2 mutated genes and have the condition. There is a 1 in 2 chance the child will be a carrier, and 1 in 4 chance the child will be unaffected. This is where genetic counseling comes in, and it's an incredibly valuable resource. They can review family history, explain inheritance, discuss testing options for diagnosis, carrier identification, or prenatal testing. The goal of genetic counseling is to provide information and support to help families make informed decisions. It's about empowerment through knowledge, understanding implications for the individual, siblings, and future generations. So, we've covered a lot of ground in our 10-minute masterclass on congenital hepatic fibrosis. Let's do a quick flyby summary to lock it all in. We learned that CHF is a rare genetic liver condition you're born with. It's characterized by scar tissue. That scar tissue affects blood flow and leads to portal hypertension, the key symptom, an enlarged liver, an enlarged spleen, most seriously bleeding from varices. It's often linked with kidney problems, specifically ARPKD, so doctors will always check both organs. Remember, this is not cirrhosis. The liver cells themselves can be quite healthy. Diagnosing CHF is a methodical process: exam, blood tests, imaging, endoscopy, biopsy, or genetics. Blood tests often show surprisingly normal liver function, but low platelet counts from splenic sequestration. Treatment focuses on preventing problems: beta blockers, endoscopic banding, antibiotics for cholangitis, and transplant when needed. In the most severe cases, a liver transplant or combined liver-kidney transplant can be definitive. It's a comprehensive approach. Avoid alcohol, eat well, stay on meds, keep appointments, and get genetic counseling. Living a full life with CHF is absolutely possible. It requires a partnership between you and your medical team. Your role involves avoiding alcohol, eating nutritious food, and being careful with medications. Stay on top of medical appointments and seek genetic counseling if needed. While a diagnosis of a chronic illness can feel overwhelming, knowledge is power. Thanks for joining me. Stay healthy, and I'll see you on the next one.